Great. It's a pleasure to discuss Ninja with you. So the rationale for Ninja is that nephrotoxic AKI is one of the most common causes of AKI in critically ill or non-critically ill hospitalized children, and that we felt a portion of it went unnoticed due to a lack of systematic kidney function surveillance. There were multiple studies that showed that children who were receiving multiple nephrotoxins were only getting a serum creatinine measured at least every 4 days, 50% of the time. And since nephrotoxic AKI is non-oliguric, if you're not measuring serum creatinine, you're not going to find it. And given this fact, and it's very nice to see the AKI bundles that you heard about before, reducing nephrotoxins, we need to understand that we don't have a medication yet that will prevent AKI. But avoidance of nephrotoxins that are unnecessary is one of the modifiable risk factors for acute kidney injury. So we felt that if we could identify patients who are at risk, if we could institute systematic creatinine monitoring reliably, we may be able to avoid acute kidney injury. And our vision statement, and this goes for adults as well, is that children should only get the nephrotoxic medications they need for the duration they need them. And that sounds like a pretty obvious statement, but many of us think that giving multiple nephrotoxins is just part of the cost of doing business in a quaternary healthcare setting, and people have not been judicious about the nephrotoxins they're providing. So we know that this is very common, and we think that it's occurring at higher than previously recognized rates, but we feel that a bunch of it goes unnoticed. And so we again thought that more reliable surveillance would demonstrate that an epidemic existed. So we developed in Ninja an EHR, electronic health record-based AKI screening intervention to assess for changes in AKI prevalence or duration as an outcome measure. But we developed a screening system to reliably quantify the rate of exposure to nephrotoxic medications in the non-critically ill pediatric population. We did not go into the ICU because acute kidney injury is multifactorial in the ICU, and from sepsis, hypotension, it's very difficult to disentangle whether or not the AKI was a result of nephrotoxic medications. But outside the ICU, we felt we'd have more understanding. So we wanted to find these patients prospectively. We wanted to reliably monitor serum creatinine for evidence of injury, measure exposure and injury rates over time, and then use these triggers within the electronic health record to make the process more efficient. So I'm not going to go into why we chose these two criteria. It's based on a lot of epidemiologic work in children, but children who receive 3 or more nephrotoxic medications on the same day, not that they're prescribed, they actually have to receive them, or an IV aminoglycoside for 3 or more days. Certain medications that may be given less than daily or intermittently, like contrast, amphotericin, cidofovir, would count as one medication of 3 for the 6 days after they were administered. The definition we used went from P-rifle, and we changed that to KDIGO criteria, again looking at the creatinine criteria since urine output is rarely affected in nephrotoxic AKI. And we developed 4 outcome measures that were novel. One was the high nephrotoxic medication exposure prevalence rate per 1,000 patient days. So in each week, we would look at how many patients were exposed in one of those 2 ways, 3 or more nephrotoxins at the same time, or an IV aminoglycoside starting on day 3, and divide that by 1,000 patient days from our hospital census. Then we looked at the AKI prevalence rate by KDIGO per those 1,000 patient days. Now, if a patient was exposed for more than 1 week and they developed AKI in week 2, we would ascribe that AKI development into the week that they were exposed. Otherwise, it's hard to generate the statistical process control charts. Then we looked at the rates of high nephrotoxic medication exposure, or AKI per high nephrotoxic medication exposure, so basically just a percentage. And then we looked at this concept of the AKI intensity rate, which is the rate we thought we would impact first. we looked at how many days a patient had AKI per 100 days of nephrotoxic medication exposure. And our thought was, if we were monitoring serum creatinine more often than every 4 days, but instead daily, AKI would be detected earlier and the clinicians would do something. Stop the nephrotoxic medication, maybe look at the blood culture results to see if gentamicin needed to be given, or get a vancomycin level. So the process that, and in our situation, the pharmacists are the ninjas. They would create and receive daily reports, verify and validate that the patient was exposed in one of those two ways. They would provide the recommendation for serum creatinine screening daily. They would also make recommendations about withdrawing nephrotoxins if it was recommended. And then we had a data analyst that compiled the registry from our pharmacy reports, and we would generate the metrics and the run charts. What we did not do was we did not dictate medications that could or could not be given. We allowed physicians to be physicians. The other thing we did not do is we did not allow this alert to sit only in the electronic health record. We did not, and we could actually have had our electronic health record order a daily creatinine in patients who were exposed. But on patient rounds with the families, we discussed that this patient has high nephrotoxic medication burden. We want to get a daily creatinine and why we wanted to do that. And that actually generated a lot of positive feedback in the entire institution to recognize acute kidney injury, to recognize nephrotoxic medication burden, instead of allowing it to sit in the electronic health record. This is the report from Epic that our pharmacists receive every day at 11 a.m. You can see patient information, their last 3 creatinines, validation that these are in fact nephrotoxins being given IV. And here's our process map. So once a patient is exposed, a daily creatinine is recommended and AKI status is monitored. In the exposure surveillance loop, the patient stays on the daily list until they're no longer exposed, and then for 2 days after that lack of exposure, because we found that 11% of acute kidney injury occurred in the 2 days after the exposure was stopped. If a patient developed acute kidney injury, then they would be monitored every day with the serum creatinine until their creatinine returned to baseline for at least 5 consecutive days, or if they had AKI for 30 consecutive days, at which time we closed the record because we felt we had demonstrated enough AKI. So our initial results span, which were published now 5 years ago, span the first year of our project at Cincinnati Children's. We had 32,000 admissions, 4,500 were excluded because they were in the ICU, and then we had about 6,000 repeat admissions. So over the course of a year, about 22,000 unique patients, 726 of them were exposed in one of those 2 ways, with 945 total exposure events, so about a 25% recurrent exposure rate in certain patients. This represented about 3% of our non-critically ill patient population at any one time, or about 25 patients a day. Now, these weren't 25 unique patients a day because patients are obviously exposed for many days in a row. What was really gratifying is we had 99% compliance with the daily serum creatinine monitoring in all high nephrotoxic medication exposed patients. So we absolutely know the phenotype here. This was not a once every 4-day phenomenon. What we found was that initially the pharmacists were doing manual review of the MAR, of the medical activity report, to look for exposure. And once we implemented an electronic health record generated alert, the exposure rate went up. So our detection rate went up by about 27%. And when we looked at various medication classes or specific medications, we found a number of interesting observations. In blue, you have the prevalence of any particular medication or class in the exposure group, and in red, in that medication prevalence in the AKI group. What's really interesting is these do not add up to 100% because remember, it's just you have to be one of 3 medications. So NSAIDs, which are a big deal, actually do not account for a significant amount of exposures if they're one of 3 medications. But in terms of the contribution to AKI, very much outsized. Our surgical team, in fact, our orthopedic surgeons for the most part, use these data to get IV acetaminophen on formulary and to get away from ketorolac because they saw these data. We also found an outsized proportion of AKI to exposure with vancomycin, as well as for pip/tazobactam. And I will not show you these data, but we're about to submit them for publication. Our oncology group has moved away from pip/tazobactam for fever and neutropenia to cefepime, and we've decreased the AKI rate by 85% in our oncology group without any increased infection rates. Here are rates of AKI per 1,000 non-ICU patient days, and it went up a little bit and then went down a little bit. But, and this number of 2.8 per 1,000 may not be all that meaningful, but if you put it in context to other rates that we're required to report in the United States, catheter line-associated bacterial systemic infection and catheter-associated UTI rates, our AKI rates are 10-fold higher than CAUTI, 3-fold higher than CLABSI. So this is an epidemic and something we should be paying attention to. What I can also tell you is that the rate of AKI that we initially had was 25%. 1 in 4 patients exposed in one of these 2 ways developed acute kidney injury. Do we talk about that to our patients and their families? When a patient gets rituximab, or when a patient gets Cytoxan, or when a patient gets any other medication, usually in the oncology world, we talk about the major organ damage that could occur. Those do not occur at 25%. I would guarantee no one tells a family that their patient has a chance of acute kidney injury of 25% if they get it for more than 3 days. So this is an epidemic. This is the AKI intensity rate, and in fact, we found what we'd hoped we find, that in the first year we decreased that rate, so that's the days in AKI per 100 days of exposure, and we decreased that by 42%. This is not a tautology. We also looked to see, did the days of exposure per days of AKI go down? And it did. So people were actually reducing medication exposure when when they found a patient had AKI. This was associated with 908 days of AKI avoided in that year. Many quality improvement projects are not sustainable, so we continue to calibrate this and make this easier for the pharmacists, and we reported the 3.5-year success of our project, or outcome of our project, about 2 years ago now, and we have found a sustained reduction in exposure rates over that period of time. That's a 38% decrease in exposure rate. And we have also demonstrated a 62% decrease in acute kidney injury rate. We decreased the initial 25% acute kidney injury rate per exposure down to 15%, so it's still happening 1 in 6 times, and we haven't been able to move that needle subsequently, which tells me there are other factors other than quality improvement initiatives that we'll need to use to improve AKI rates per exposure. And our intensity rate remained decreased after the initial rate. So if we put this all together, had we not put NINJA in place and we had the same exposure rate and the same AKI rate, we believe we've avoided in 3.5 years over 600 unnecessary exposures and nearly 400 AKI events. So we then received some funding from the Casey Lee Ball Foundation and AHRQ to disseminate NINJA at 9 pediatric institutions in the United States to measure the impact of NINJA on these hospitals and to assess, again, the association between different context measures. Hospitals are going to be very different than Cincinnati Children's, very different than Mayo, et cetera. So we wanted to see how did these contextual measures affect the dissemination of NINJA. We found a very similar acute kidney and nephrotoxic medication exposure rate at the hospitals. We demonstrated a 30% reduction in AKI, in the AKI rate at these hospitals, exactly what we found in our own hospital, and to the same level of 1.3 exposure AKI events per 1,000 patient days across 9 hospitals. And we found the exact same AKI rate per exposure of 15%. So we believe that this is a valid program. We did not impact the intensity rate, but the intensity rate of the collaborative is exactly what we see now at Cincinnati Children's. So we already had buy-in from these hospitals. An interesting component here, just from a quality improvement standpoint, is that patients who already started with low rates of acute kidney injury and exposure maintained those low rates and they didn't improve. But the centers that had high exposure and high AKI rates, all of those centers improved, and all but one got to this benchmark, which we think is achievable. NINJA has now been accepted as the next hospital-acquired condition for the Solutions for Patient Safety and will be rolled out at 140 pediatric institutions across the United States and Canada, starting actually next month. So just have to thank Devesh Dahali, who's my NINJA partner in crime, and these are the group of investigators that worked with me across the 9 hospitals. Thank you very much.